Hello everyone, and welcome to our module on treatment of TIA and stroke. So let's review what a stroke is. This is sometimes called a brain attack to contrast it with a heart attack, and it gets its name because patients appear struck down. It's a sudden loss of neurological function, and if the symptoms resolve in under 24 hours, we call it a TIA, which stands for transient ischemic attack. If the symptoms take more than 24 hours to resolve, or if they persist indefinitely, we call it a stroke. 80% of strokes are what we call ischemic, and that means that there is insufficient blood flow to an area of the brain, and this can happen for three general reasons. The first is thrombosis. That means a blood clot forms in one of the arteries in the brain. The other is embolism, and that's where a blood clot travels from a distant site to the brain, usually the heart or carotid artery. And then finally, there can be systemic hypoperfusion if you have very low blood pressure, like from shock, for example. And the symptom onset for patients with ischemic stroke is often slightly longer than other types of strokes, over several hours, especially in board questions. If they tell you the symptoms come on over a few hours as opposed to a sudden abrupt onset, that suggests it's more likely an ischemic stroke. In real life, there's a lot of overlap of symptomatology. 20% of strokes are hemorrhagic, and this means there's bleeding in the brain, and these will have sudden onset because a blood vessel suddenly bursts and causes bleeding and causes the abrupt onset of symptoms. The best first test in anyone who may have a stroke is a non-contrast CT of the head, provided that the patient is stable. This lets you determine whether there's bleeding or not. We'll talk about that in a minute. Now, diffusion-weighted MRI is the most accurate test, but that takes time and is usually not done in the acute setting. So let's revisit the head CT and why you want to get it. As I said, it lets you know whether this is an ischemic or hemorrhagic problem. If it's an ischemic stroke, meaning you see no blood or bleeding on the head CT, then you must consider thrombolysis. Thrombolytic drugs that bust up clots are the one intervention we have that improves outcomes from stroke. Everything else we do for stroke is aimed at preventing second strokes, but there's not much we do for the initial stroke itself. So thrombolysis is very important, and you have to consider this if it's an ischemic stroke. If it's hemorrhagic, thrombolysis is contraindicated. In these patients, we lower the blood pressure, reverse anticoagulation, and sometimes do surgery to get the blood out of the brain. Now, important thing to note in strokes, there's no benefit to heparin or warfarin or antiplatelet drugs. So this is very different from a heart attack. In a heart attack, we often give heparin and other blood thinners and antiplatelet agents, but they don't have a role in acute stroke. Patients will sometimes take these for the long-term prevention of second strokes, but that's very different. In the acute setting in the emergency room with a stroke patient, you don't need to worry about these drugs. So let's talk about thrombolysis for stroke. There is a 3-hour window during which clinical trials have shown a benefit to giving these drugs. So one of the first things you want to determine when you see a patient who may be having a stroke is how long their symptoms have been present. The drug we generally use is TPA, which stands for tissue plasminogen activator. It's also called Alteplase, and this is a powerful clot-busting drug that can lyse the embolus and reperfuse the brain. The problem with TPA is it carries a very significant risk of intracerebral bleeding, so we only want to give it to appropriate candidates. So first you want to determine if they're within that 3-hour window, and then you want to run through the long list of contraindications to see if they have an increased risk of bleeding for which you might not administer the drug. So what are some of the contraindications? Stroke or head trauma in the past 3 months, arterial puncture in a non-compressible site in the past week. So for example, if you've had an angioplasty, you may not want to get this drug. Internal bleeding or trauma, high blood pressure raises the risk of bleeding. Elevated INR, low platelets, or elevated PTT. If the glucose is very low, you need to treat that first. And any history in the past of intracranial bleeding generally makes someone ineligible for TPA. The hospitals that do this the best are called stroke centers, and when you come in, they activate a stroke team that quickly runs through this list of contraindications and determines if you're eligible. They then administer the TPA and take you to a neuro ICU for close monitoring afterwards in case you develop stroke complications or bleeding from the drug. After someone's had a stroke, let's talk about what you do. Most patients get aspirin for prophylaxis or clopidogrel if they're allergic. These are antiplatelet drugs given to lower the risk of secondary strokes. Most patients get an EKG to look for atrial fibrillation. So recall that patients with atrial fibrillation can form blood clots in their left atrial appendage. Recent studies have shown that even patients who have normal sinus rhythm on their initial EKG often have silent runs of AFib if you monitor them for weeks or months. So we are looking harder and harder to find evidence of AFib in people with stroke, and if we do find evidence of a stroke, they will be placed on warfarin or another anticoagulant. Patients often get an echocardiogram after a stroke to see if there's a blood clot in the heart or to see if there's a PFO. A PFO is a patent foramen ovale, and in theory, blood clots from the venous system can cross to the arterial side through a PFO and cause a stroke. And then most patients who've had a stroke get a carotid ultrasound because surgery is considered when there's more than a 70% stenosis. So we use something called the CHAD score to decide who with atrial fibrillation needs to be on blood thinners like warfarin. And it's a score where you're given points. If you have heart failure, you get 1 point in the CHAD score. Hypertension is a point, age over 75 is a point, diabetes is a point, and stroke is 2 points. And anyone with greater than or equal to 2 points gets warfarin. So someone who's had a stroke automatically needs anticoagulation if they have atrial fibrillation. Patients who have 0 to 1 for a CHAD score can sometimes be treated with aspirin, but no one who's had a stroke will ever be a 0 to 1. There's also something called the CHADS VAS score, which has become popular recently, and you'll see on your clinical rotations. This is very similar to the CHAD score, but it adds a point if you're female. It gives you 2 points if you're over 75, and it adds a point for vascular disease. And the scoring is done the same as the CHAD score. Greater than or equal to 2 is warfarin, and 0 to 1 is aspirin. Once you decide a patient merits anticoagulation, the choices are Coumadin or warfarin, and the problem with this drug is it requires regular INR monitoring, and the goal is to thin the blood to 2 to 3, but every patient responds differently, so you have to titrate the dose. There are now several new drugs called novel anticoagulants. Some of those are rivaroxaban and apixaban. These are factor 10 inhibitors, and the nice thing about these drugs is that you don't have to check the INR level. It's the same dose in everybody. There's also a drug called dabigatran, which is a direct thrombin inhibitor. And keep in mind that whether patients have AFib or go back to sinus rhythm, they still have to stay on anticoagulation because the stroke risk persists. And that concludes our module on management of TIA.